I always do assessment, reassessment, and then also trying to have the patient feel something. I mean, it's one thing if I see an objective change, but I want the patient to feel a change too. So they buy in, to the exercises that I'm going to have them do. Leslie's coming to us with intermittent right/left posterior pain right along the lines of the SI joint. Today it's a little bit more so on the right than the left, but it varies back and forth. Is that correct? Okay. I'm going to have you just segmentally bend forward, Leslie, for me, and just drop your head first and just try to go one vertebrae at a time as you're bending forward. And one of the things we look for is what's called relative flexibility and seeing how Leslie distributes her motion through her spine. So we can see that she gets pretty good thoracic motion, and then she has pretty limited lower lumbar motion here where she's not reversing the curve of her spine, and then she has limited pelvic motion, so she doesn't get a full forward bend. And then, so to summarize those hip motions, she has limited medial on the left, limited lateral on the right, which suggests to me that there is a pelvic asymmetry, which we picked up on when she was in supine. What we're going to try and do here is have Leslie work on something here to try to change the relationship of her pelvis. There's many ways to approach this problem, but what we're always trying to find is a way that the patient can do this at home. I could manually go in and correct her pelvis, and we would see a change in relationship between her hip joints, but I want Leslie to be able to do this by herself. So Leslie, what I'm going to have you do is turn your knee in, lifting your foot up toward the ceiling, turn that knee in, and then very small lift off pillow and back down. Okay? So turn in. Good. And lift. Now when you're doing this, Leslie, I want you to make sure that your leg doesn't come forward toward me. It stays back, and you activate your abdominal wall, pulling your belly button in toward your spine. We're going to do a few of these. We like to equate the pelvis with the shoulder. They're very similar in how they function. And of course, I'm going to create some parallels between the pelvis and the shoulder, but we really want to think about the socket just as much as we want to think about the femoral head. So, and I think that's where we might think of it globally. We'll have someone tilt their pelvis globally, but we don't think about how the two halves of the pelvis have to move in reciprocal fashion relative to each other. They don't move like this as you're walking. They move like this. One half goes one way, one half goes the other way, and we lose that iliosacral motion, and it creates problems in the spine as well as in the hip joint, and can have far-reaching effects up and down the whole kinetic chain. What we always want to do is go through an evaluation, look at the impairments, but look at how they relate to what we're discovering as the underlying root cause, and then we can prioritize our exercises much better and teach them much more specifically to the patient when we know what the specific problem is at hand.